All right, everyone. Happy Wednesday. I hope you had an amazing long weekend, but we're back ready to jump into birth brilliance. We're going to talk about all things labor and delivery today. So, if you have never joined with us, my name is Jennifer Bonner. I am one of the tutors here at Archer Review. I actually serve as the tutor team lead here. And so, a lot of what I do is working with students one on one through private tutoring. I do small group tutoring, and I do a lot of our free webinars. So, why do I get to do Birthing Brilliance? Well, I have over 15 years of nursing experience, and a lot of those years were in labor and delivery, postpartum. That is what I love. That's my bread and butter. I went back to nursing school or went back to grad school to become a certified nurse midwife and finished my doctorate shortly thereafter. So I spent a lot of time, 4 to 5 years in a OBGYN clinic here in my town where I live, serving women of all ages, from puberty all the way to menopause and beyond. So this is absolutely in my wheelhouse. Love this so much. I have been with Archer for 2 years, and like I said, I serve as their tutor team lead. So I'm delighted to be with you this afternoon. So I'm sure if you have joined us before, you probably already know the question I'm about to ask you, but we're going to jump into something we call Slido. So if you're familiar with Slido, you can either grab your smart device and click that link right there on your screen, scan that link. It'll take you right to our Slido poll for today, but it's a great way to just be able to interact with other students around the world. Or if you are on your computer, you can log into slido.com, enter in that code capital A, capital R, capital L, lowercase and then uppercase D. And let me know, where are you joining us from? North Dakota. All right. Welcome, neighbor. I'm in South Dakota, so welcome. Arizona, Minneapolis. I was just there over the weekend presenting to the Minnesota Student Nursing Association. It was an amazing opportunity. So maybe you were there, maybe you joined us. Maryland, Boston, Colorado, Chicago, Illinois, Nevada, Canada, Clearwater. Oh, we love vacationing there. What an opportunity. California, Ontario, Utah, Oregon, Texas, New Jersey. Awesome. I am so excited to see so many of you joining us. And it's really neat to see where everyone is joining from. Because you know what? Regardless of where you are, many of you are in other countries, and that is totally fine. But what brings us together is nursing. And so I am so excited that you're here. And I'm wondering, how do you feel about labor and delivery? So, a lot of times, this is one of those subjects that, it tends to have some feelings. Some people are really excited about it. Others are like, oh, I will do it because I have to. But regardless of how you feel about women's health, labor and delivery, it is a really important aspect to understand for our clients, but also for the NCLEX. So it's really important information. So we're going to try to break it down for you over the next 27 minutes or so that we are together. And we're going to start by talking about delivery methods. Now, we know if there's a baby in there, it has to come out some way, right? So, who can tell me what is the most common type of delivery that we see? If you're on Zoom, go ahead and put that in the chat. If you are on Facebook, Instagram, TikTok, you can let me know in the chat there as well. But where do we see the most types of delivery? Yeah, vaginal deliveries. Vaginal deliveries are the most common that we see, but it is not the only one that we see. So we're going to talk about vaginal deliveries. Now, obviously, a vaginal delivery, a baby is born through the vaginal or the birth canal. And typically see this at all types of ages. We see preterm births that come through the birth canal. We also see postterm births that come through the birth canal. And typically, this is the recommended delivery method, unless there is a reason for a cesarean section or a C-section. Now, what are the benefits? Well, typically, moms tend to recover a little bit better. They don't have as many infections, and babies have a lower respiratory issue rate. So tell me, why do you think that is? Why do you think a baby that was born through the vaginal canal would have a less or have a smaller chance of developing respiratory issues. What do you think? Because of the compression, Emily, yes. So think about it. As that baby is being born, they're getting squeezed, right? Their head gets squeezed, and we see some type of decel. This isn't really specifically about delivery, but what type of decels do we see with head compression? Remind me in the chat. What types of decels do we see with head compression? You got it. Early. Excellent job. Yes, we see early decels with head compression. So they get their head squeezed, and then the rest of the body gets squeezed as they come out. Now, what would we be needing to get rid of through that squeeze? What would we be needing to get rid of through that squeeze that the baby's receiving going through the birth canal? What do you think? Yeah, amniotic fluid. We're getting rid of that amniotic fluid that they still have in their system. So when they get that out, that helps them as far as the respiratory system goes. Now, the other type of delivery method is going to be a C-section or a cesarean section. Now, somebody remind me in the chat, what types of reasons might we have for a C-section delivery? What type of reasons might we consider a C-section versus a vaginal delivery? So not always preterm. If they've had previous C-sections, typically if they've had two C-sections before, a lot of times they will recommend a C-section. If they have had a particular type of incision to the uterus, and we'll talk about that in a minute. Macrosomia sometimes is an indication for a C-section. If they have active genital herpes, yes, excellent. A placenta previa. Breech presentations. There are some places throughout the country that will do a breech vaginal birth, but for the mostly we do a C-section for a big baby or for placenta previa or breech births. Yep. Failure to progress sometimes. Excellent. If they have an inadequate cervix, their cervix isn't doing their job. They can't get that baby out. Yes. X. Very good. Excellent job. You got it. So there you go. Somebody's asking me to maximize my screen. I hope that helps. Let me know if it does not. So, yes, there are a lot of reasons that we would consider a C-section, and many of the ones that you guys just listed are a lot of what goes into that decision-making process. Now, we know with a cesarean section, this is where that baby is delivered through a surgical incision in the abdomen and the uterus. So we see an increased risk of infection, increased risk of pain issues with a C-section. Also, we see increased risk of blood loss, blood clots. Also, this can make breastfeeding a little bit more challenging because it often, not always, but often can delay when that starts. Now, all throughout the country, we're making a shift to where women are able to have a successful latch in the delivery room. It does require a little bit more surveillance, which is totally fine. But again, we know just like everywhere else, we are short staffed in the hospitals. So having that support staff there to make sure that this is a healthy transition is really very important. Now, once a woman has a C-section, that actually increases her likelihood of having another one because of that increased risk of what? What goes up with labor after having a C-section? Excuse me. Nope, not clot, not infection, not sutures. Uterine rupture, you're right. So what happens when we have a C-section? We make that incision into the uterus and there's some scar tissue there. So that actually weakens that uterine muscle, increasing their likelihood of a uterine rupture afterwards. So we want to make sure that we're very careful about that. Now, many of you had suggested reasons for a C-section before. Multiples is one that we missed. So if there are multiple babies, a lot of times they will consider that for a C-section. There are many places throughout the country that women who, even if they are going to deliver their twins, triplets, quadruplets vaginally, that they do that in the operating room just for that risk there. If the baby is in a bad position, they're going sideways or they're bottom first, which is called breech. Placenta previa, we know that a baby can't deliver through that placenta. So a lot of times they will recommend that as well. So we know that this is a major abdominal surgery. And so I have had women that came in and they said, you know what, I'd prefer to have a C-section. That way we can time it. And having those conversations about this is a major abdominal surgery comes with risks, and going through those so that the client can make an informed decision is very, very important. So we talked about this just a little bit, but when we're talking about a C-section, one thing that's really important is that we want to know, especially with previous C-sections, what type of an incision was made. The most common one that we see is a low transverse incision. So it's low in that uterine segment and it goes across. So it's horizontal, like the horizon. And so a lot of times with this one, they're less likely to rupture, but it does not give them a 0% chance. And this has been something that is now more common. So most of the time when you see a C-section, typically it's going to be that low transverse. It does have a lower risk of uterine rupture. Now, the other one that we used to see quite frequently, especially in emergency situations, is that vertical, or we call it a classical incision, going up and down. And so with this type of incision, we have muscles that are doing the majority of the contracting that are getting cut. And so that does make there a greater risk of rupture. And so typically, if we can help it, women who have a vertical incision into their abdomen for one reason or another are typically encouraged and counseled not to labor and have a VBAC. So, like I said, I'm sure there are places throughout the country that will allow this, but for the most part, women who have a vertical incision, we tend to do C-sections thereafter because of that risk of rupture. Okay, does that make sense? The different types of incisions. Any questions there? Perfect. All right. So, what about a VBAC? So, a vaginal birth after cesarean is termed VBAC. So, what would allow a client to be able to VBAC? Well, it's really important that if they've had a C-section before, that we have the discussion of the risks that could come with that. So, one of the big ones, like we just talked about, is uterine rupture. Now, there are lots of reasons why women have a C-section. If baby's not tolerating labor, are ones that we see. Maybe they've failure to progress. Now, those are not things that are going to necessarily affect the next labor. And so having that conversation. Now, what happens if it was a macrosomic baby and mom is diabetic? Well, chances of that occurring again is very high. So we have that conversation with our client so they can make an informed decision. So when we're considering a VBAC, there is a calculator that our providers use as that due date gets closer. If the score is less than 50%, typically it's not recommended. Things that we consider in this factor in this calculation is weight gain from their starting weight, delivery history, but again, it's really important that we make sure that they understand what those risks and benefits are. There are some women that are like, you know what? I had a C-section. I'm totally fine with that. I know what to expect. Others are like, I really want to have that vaginal delivery. So I really want to try a VBAC. Not all hospitals offer this, but it is definitely the conversation to have. Now, what's the problem if someone were to have a uterine rupture? What's the big concern there? What do you think? Let me know in the chat. Hemorrhage is a big one. Yep. What else? Think about what's in there. So we have a baby that's connected to the placenta, fetal distress leading to death. There we go. Yes. So we have the risk of blood volume, so hypovolemia. We have baby not getting what they need. And so the survival rate of infants that are in the middle of a uterine rupture is about 85%, which is good, but a lot of times we see that while they're in the hospital where we can get them taken care of. A lot are born with brain damage and have long stays in the NICU depending on their specific situation. So it is a big thing to consider. All right. So when it comes to vaginal deliveries, sometimes these babies, they just have a little bit of trouble. And this can be for a variety of reasons. It can be how the baby is made. Maybe they just have a very large head. Maybe mom is exhausted and is unable to push in an adequate fashion in order to birth this child. So a lot of times we have what's called a vacuum delivery. Now, I'm not talking about sweeping your floors kind of vacuum or a Roomba type of vacuum. This is kind of a suction cup that is put on the baby's head. We apply some suction and then we gently guide as mom is delivering. So we are going to, again, we want to make sure that we discuss the risks and the benefits. We want to be very careful of where this vacuum is placed because remember, they do have those soft spots that can cause some damage. And so we just use some gentle traction to help guide that baby out of the birth canal. Now, this is not without risks. This can lead to injuries like hematoma, skull fractures, brain damage, even cerebral palsy. So it's really important that the provider is very careful when applying these and that we use them for the purpose that they're intended for. If we can't, if there's an issue and babies not being delivered that are used from time to time, one of these is the forceps. Y'all, the first time I saw these, I was thinking salad tongs. That's just kind of what it reminds me of. And so basically, what this does is it grasps around the baby to help guide them out. Now, this is a operative type of vaginal delivery, and so these forceps get put inside the vagina next to the baby's head to help gently, hopefully, guide them out. Um, and it's really important. Now, think about all the things that are in this space as we are grasping. Right? There's nerves. There's skull here, so we have to be very careful. Um, because of the risks that come with these, a lot of providers choose to use the vacuum if necessary because we see less injuries. Um, so a lot of times they will use this if mom can't push very well, high blood pressure, if baby just needs to be, maybe they're in the wrong position, mom's exhausted. Um, so we want to be very careful with this. Now, somebody tell me if we put these in the wrong spot and we have some damage, we could have some palsy issues, right? But what else could we do? What else do you think cause could be caused by using the forceps? Think about what is up here. Compression of the head. So we could have some skull concern, right? So we want to be very need a little extra help. Let me suggest one of our small group offerings. These ladies on our team are absolutely amazing at what they do. This is a great value. So basically for $25, you get an hour session in a small group setting, which is typically 20 students or less. And you have the opportunity to do what we're doing now, interact one-on-one through chat with our tutors and ask those questions. We're like, Jennifer, I don't understand why someone would use forceps over a vacuum, or when would we use one of these? You can ask these questions. So scan the QR code there, check out the amazing offerings that we have coming up. I know you will not be disappointed. We have some awesome offerings coming up in the next few weeks. All right. So we've talked about delivery a little bit, but how do we know if someone is in labor? Now, it's really important that we know what those signs and symptoms of labor are. So, somebody let me know in the chat, what are some signs and symptoms of labor that we might see? Some signs and symptoms of labor that we might see. So someone is asking, is it true that a VBAC is only allowed after 5 years of previous C-section? No, that is not necessarily true. This is in going to be different from client to client depending on what their situation is, but it is a very good conversation to have with the provider. But no, I have not seen that being the norm of it has to be 5 years. Okay, is their cervix dilating? Excellent. Amniotic fluid leaking? Yes. Are those contractions getting closer together? Are they getting more intense? Yes. Excellent job. You guys are getting it. So it's really important that we understand just because a woman is having contractions doesn't necessarily mean that she is in labor. So it's important that we understand the difference between true and false contractions. When it comes to true labor, these are going to be regular contractions. And that interval in between them is getting shorter and shorter with time. Now, typically, what I would tell a woman is you're going to know you're in labor if you imagine yourself in a burning building, you're headed down the stairs, and even though the building is burning around you, you have to stop and breathe through those contractions. So it doesn't matter if you're moving, if you're sitting down, those contractions are going to continue to come. And a lot of times what happens is contractions start in the back and they move around to the front. Now, false labor could be them having contractions, but it's not doing anything. It's not causing any type of cervical dilation or effacement. These contractions can be irregular, but they're not getting closer together. Typically, when you stop doing whatever it was you were doing, a lot of times those contractions will go away. They're, like I said, typically irregular. They're not generally very strong. And a lot of times, all you're feeling is in the front. Now, when do we tell mom to go to the hospital? Typically, a woman is in true labor and she's ready to go to the hospital when she's having contractions every 5 minutes, lasting for 1 minute each, and that's happening for at least an hour. So we call that the 5-1-1 rule. She's having contractions every 5 minutes, lasting for 1 minute each, and that's happening for an hour. That's typically when we send her to the hospital. Amniotic rupture. Many of you mentioned this is that when woman starts to have leaking. Now, a lot of times there's a lot of pressure there. Sometimes women do have accidents. They do leak some urine. And so it's really important that we understand what is this fluid that she is experiencing. Now, somebody tell me in the chat, how are we going to figure out what this fluid is? How do we determine whether it's urine or amniotic fluid? What are some options here? Yes, false contractions would be Braxton Hicks. Great question, patience. Nitrazine test. Yes, you got it. So nitrazine is a pH paper that we dip into this fluid. If it turns blue, that typically lets us know that we have amniotic fluid there. Now, typically about 90% of the time, women are not going to have this big gush like we see on the movies. Typically, it's just a slow trickle. And so sometimes women are waiting for that big gush of water all over the grocery store floor. But a lot of times it can be just a constant trickle as well. So we need to make sure that we're educating them on what this can look like. So there's a couple terms that we need to understand when it comes to ruptured membranes. We have PROM, premature rupture of membranes. Now, premature rupture of membranes means that the water has broken before labor has started. Now, PPROM is when we are preterm. So somebody remind me, what is that preterm area? Let me know in the chat. What is that preterm area? Preterm weeks gestation, 20 to 37. You got it. So if water breaks in that amount of time in that gestational age, we call that pre-prom. P or P-prom. Now we also have AROM. AROM is where we artificially rupture that bag of water. A lot of times, doctors will go in, it looks like a little crochet hook. They'll just nick that bag and allow that fluid to flow out. Now, somebody remind me, why might we consider rupturing membranes? Why might we want to artificially rupture membranes? Someone is asking, is the Fern test the same as the nitrazine test? No, ferning is a little bit different, but it is a way to determine whether we have amniotic fluid. And so what we do is we take a little sample of that fluid, we put it on a slide, wait for it to dry, and when we look at it under the microscope, it makes this beautiful crystallized ferning appearance. Great question. Yeah, so to induce labor, to augment labor, those are reasons why we might consider artificially rupturing the membranes. Very good. So we determined that true labor is having cervical dilation, right? So how do we determine about cervical changes? Well, there's two terms I want you to understand. One is dilation. Dilation is the opening, how big that is getting. The other is effacement. Effacement is the thinning out of the cervix. So typically the cervix is going to start out like a thick little Debbie donut is the best way I know to describe it, thick plush. And then as it effaces, it becomes thin like a pancake to where you can hardly feel it. So we are assessing cervical dilation. So how large is that opening? Typically, we're going to use two fingers to figure out how open that is. It can be closed all the way up to 10 centimeters. And effacement is that thinning out. So if it is completely thick, just like that little Debbie donut, it is 0% effaced. And then it effaces. It gets thinner all the way to 100% effaced where you can barely feel that cervix. Something else to consider is the station of the baby. And this tells us how far down in the pelvis is that baby. Why would we be concerned about the station of our baby? What do you think? Let me know in the chat. Yes, Ricky, this will actually be available on our Facebook page, our YouTube channel. As soon as we're done, the recording will be available for you there. Excellent question. Yeah, it tells us how close to birth are we getting? Tells us baby's on the way. Now, this is how I remember it. So 0 is at the ischial spine. So when the top of the baby's head gets to the ischial spine area on the woman's pelvis, they're at 0 station. The higher up they are, they're not as close to delivery. So those are negative numbers. And the closer they get past that 0 station, we get more excited. So we get more positive. So +1, +2, +3, that baby is getting closer to delivery. All right. So let's look at a question together before our time is up here. So we're going to switch back to Slido. All right. So we have a client that presents to the obstetric floor at 39 weeks gestation with irregular contractions. After we get our client situated in labor and delivery and recovery room, you notice their healthcare provider enters the room to evaluate the client. Following the evaluation, the healthcare provider exits the room. Shortly thereafter, we go back in. And during our discussion, the client states the healthcare provider went to order oxytocin. In anticipation of that order, we understand it's going to be administered which route? What do you think? IM, IV through a main line using an infusion pump, IV through a piggyback using an infusion pump, or orally? What do you think? What do you think? That code is capital A, capital R, capital L, lowercase and then uppercase D. All right. Let's see how we did here. Let's see our results. Many of you said IV piggyback. Yes. So this is really important that when we're giving oxytocin is giving IV and through the piggyback line. Excellent job. Now, if you struggle with trying to figure out, I saw many of you say, hey, I'm getting ready to take a OB test coming up. I'm getting ready for the NCLEX. If you're not sure where to get started studying for the NCLEX, our SurePass combo is my number one recommended package. Why? Well, because it includes on-demand videos on so many topics. I can't even tell you, but so many hours of explanation about various topics. So if you're struggling with the difference between placental previa and placental abruption, we have a video for that to break it down for you. We also, through this combo, you get access to over 2,000, almost 3,000 questions for RNs and QBank that gives you rationales as well. And we also have our 3-day live review where we go over the most high yield content in order to help you pass the NCLEX. So if you are an RN, scan that code there on your left. If you're a PN, scan that code on your right and see what this SurePass combo is all about. So here at Archer, we are here for you no matter where you are in your nursing journey. If you're getting ready to take the T's, you're pre-nursing, we have something for you. If you're in nursing school, check out our nursing school product. It is absolutely amazing, breaks down those high content, high difficulty content very, very well. We have NCLEX PN, NCLEX RN for those of you who are getting ready to take that test. And if you're getting ready to go into nurse practitioner school, you're in the thick of it with nurse practitioner school, you're getting ready to take that exam for your boards, we have something for you. We are here for you across the lifespan of the nurse, and we're here to walk with you through that. So please check out those options for you. And remember, here at Archer, we're more than just test prep. We are here for you. We want to make this process simple. We want to walk with you through this journey, and we are here to support you. So please don't ever hesitate to reach out to us. Let us know if there's a way we can support you. And we will be back on Friday with our next free webinar. It has been a delight being with you this afternoon. I hope you enjoyed our discussion on labor and delivery. Please don't hesitate to share with your friends, and we'll see you back here on Friday. Thanks so much, guys.